8-year-old male, hypoxic brain injury following an out-of-hospital arrest, past medical history, hypertension, ischemic heart disease, type 2 diabetes. He's someone who's smoked and drunk since he was a teenager. So none of what I've just said are exclusions to organ donation. I'm really describing a potential extended criteria donor, and further investigation would be undertaken to explore medical suitability for donation. It's more complex to do that when we're further away. And ironically, rather than spending the last few days preparing for this talk, I've been at work living that challenge. So we could add a rising CRP in a patient who is not hypotensive, no fever, no tachycardia. And we could throw in a urine dipstick and see some protein. And we ask ourselves, is it safe to go ahead with donation? And now, because of the remote location of the donation hospital, we're going to extend the ischemic time of those organs. So the time from cross-clamp or cold perfusion of those organs through to transplantation, that's being extended to the outer possible limit. So sometimes I think it's the cumulative challenges that means we may not be able to safely proceed with donation. And I'm starting to touch on logistics. Limited transport options is significant. So air from those northern hospitals is the only option. And we're in the tropics, so we go on cyclone warnings, and we have had cyclone warnings in the middle of a case. So is the airport going to close? Processing blood for tissue typing and cross-matching after consent is the first step in the donation process. It's a crucial step, and the labs are far away. So the lab down in Adelaide is the lab that's going to process the Territory's tissue typing blood, and to Brisbane for those Queensland centres. So early referral is essential, with a clear plan on when our family discussion is going to take place, so that we can have that blood sitting and waiting in the tissue typing lab to either be processed following consent or disposed of. For abdominal organ retrieval, getting the organs to the transplant centre is by commercial flight, and we've probably only got 1, perhaps 2 flights a day that are direct flights to the transplant centre. Multiple organs, they might be going to different cities around Australia. So we're trying to time the start of theatre so that the organs can go onto their flights without delay to reduce their ischemic time for the benefit of the transplant recipient. So the risk there is any unforeseen delay in theatre or during theatre or even before. It has the potential to mean that we miss that commercial flight and the recipient misses out on the transplant. There usually isn't a plan B. We've got to find a local retrieval surgeon for the abdominal organs. So around the time of that early referral, we're usually making a few calls to find out if there is a surgeon on site who has that skill, that capability, and how long are they going to be in town for. Otherwise, we need to fly up on commercial flights an abdominal surgeon. The thoracic retrieval teams have their own charter jets, and so they can come in and out at any time, and they slot in to our timeline, usually very effectively. And the Donate Life Queensland team has the benefit of being able to use their Premier's jet, which I'm very jealous of. But the key thing, I think, is can we time theatre to suit everybody's needs? Everybody's needs meaning the family foremost, intensive care, and the multiple transplant teams. If it's a potential donation after circulatory death, are we going to have a thoracic team putting a jet in the air and leaving their hospital for around 12 hours and sitting in the remote hospital, perhaps the patient doesn't die in the time frame to allow organ donation to proceed. Perhaps the team flies all the way back without an organ for transplant. Is that an effective use of health dollars? So the logistics are complex. I think excellent communication and collaboration, patience, and understanding of each other's needs are the key things in coordinating and managing all those challenges. There is an impact on the transplant recipients. There are less organs per donor retrieved. There are extended ischemic times. And there's also limited diagnostic capacity when we're assessing donor suitability. Our Aboriginal and Torres Strait Islander patients, or people, make up more than half of our inpatients in the Northern Australian hospitals. And sometimes it's easy to make assumptions about their views on organ donation. I found this morning's Welcome to Country incredibly moving and a real insight into the importance of spirituality in Aboriginal culture. When we assume that a family will not want donation because it's against their culture, perhaps we're choosing not to support the patient in ICU while we're exploring organ donation with the family, while we're exploring the family's wishes, the patient's wishes. When we choose not to ask them about donation, it's important to consider what that actually means. It actually means we're making a decision. We're making a decision on behalf of the family without consultation that donation is not for them. It's a well-intentioned decision, but I don't know if we have the right to take that away from the family. I don't know if that's our decision to make. Some East Arnhem women sat down with me, and when I spoke to them about donation, their response very firmly was that donation is not right for them in their culture. And then they were quiet for a bit, and then they said, "But you must ask us every time." So historically, it's been a commonly held belief that Aboriginal people did not believe in organ donation and that it wasn't accepted in their culture. However, there's generally a lack of awareness in remote communities of what a transplant is, let alone what organ donation is. And you sometimes find a level of distrust of the medical community. In other countries, successful programs have occurred when the community has been empowered to be educated and make change from within. And that's certainly what we're trying to do in the Northern Territory. And the policy of the ICU where I work is to offer organ donation to every family regardless of their cultural background. And we measure success by the quality of the conversation with the family, not by whether we get a yes for donation. We find that rather than asking a closed question about organ donation, it's more helpful to the family to promote a discussion, to talk about why we're asking, why we're actually offering this to the family. We're not taking anything from them. And there may be a collective responsibility for the decision, or there may be a significant elder who will make the decision on behalf of the family. Trust that the family will guide you, I think, is one of the tips I can offer, and know that we're empowering them to make the decision that's right for them at that time. And in that way, there is value to the family if we thoughtfully and compassionately offer donation. So given those complexities and challenges, how do we actually do? So this is the number of organ donors from north of the 26th parallel over the past 20 years. Data from ANSOD. So you can see in that first decade the rates are steady, and then the establishment of the Australian Organ and Tissue Authority 10 years ago, in this most recent decade, you see a more than twofold increase in donation rates. And that mimics the national trends. And if we actually look at donor rate comparison as donors per million of population, the dark blue being Northern Australia and the light blue being the whole of Australia, and we're looking at donors per million of population, it's not surprising that the Northern Australian rates are lower, based on all those complexities and challenges. I thought it was surprising to not see such a marked difference. And I was trying to think through what could be the reason for that. And I actually attribute it to us all, to the people who work in donation and transplantation all over Australia, to their ICU colleagues who continue to work collaboratively and passionately for the well-being of people like Arthur. Thank you.
Thank you, Kelly. Very, very interesting talk, and it certainly makes me proud to work in such a special place. Has anyone got any questions for Kelly?
Stuart?
Thanks, Kelly. That was excellent. In terms of consent rate in the Indigenous population, has that changed at all over the last 10 years with the education that you've been putting into the communities?
It's hard. I think it has increased. We've certainly had an increase in the number of Aboriginal families consenting to donation versus 10 to 15 years ago where we might have Aboriginal donors but non-Aboriginal family members consenting. Our numbers are so small it's hard to see if it's a significant improvement. What we're hearing repeatedly and what we're all each reporting is the conversations with the family are feeling better, that rather than going in and worrying that we are adding to the grief that they're going through, a thoughtful family donation conversation adds to their experience. 2 years ago, we had 2 Aboriginal families raise donation, and both went on to be donation after circulatory death patients. And they were families whose loved one had heard about organ donation in community awareness work and had talked to them. So very much the non-Aboriginal experience.
Thanks, Kelly.
Thank you.
Thanks, Kelly.